Thanks so much. We're purely a Mac-only lab, so there are clearly some PC issues. Thanks for inviting me. For the next 15 minutes, I want to discuss our work with novel magnetic resonance sensors and cancer profiling, for cancer profiling and diagnostics. So essentially, it's this work out of the Weissler Laboratory out of Mass General, funded in part as well with the MIT Harvard Center of Cancer Nanotechnology Excellence. And what I will try to talk about is essentially describe three novel and hopefully compelling technologies and cite three translational examples as well that has potential for broader collaboration with your respective disease interests. And importantly, the work that we're doing kind of subscribes to our mission statement, which is to create and leverage novel nanotechnology and microfabrication strategies to address highly unmet cancer research needs. So the space that we work in centers around scant human specimens, notably fine needle aspirates, blood, where we try to profile circulating tumor cells, exosomes, and such. So we acknowledge that the trade-off for cell numbers we get in minimally invasive and serial approaches to try and procure tissue. So that rather than getting more tissue to try to fit the needs of conventional technologies, we try to extract as much information as we can, given the tissue that we have at hand, albeit scant. So micronuclear magnetic resonance is the first technology and embraces that principle of trying to capitalize on scant human specimens. And at the risk of sounding like an Apple executive, really this is kind of the world's smallest NMR. And it's housed in a 10 by 10 centimeter footprint. And if you can think of it, there are novel technologies throughout that drives this machine. You can think of it as having a software and a hardware component. So the software, the assay, essentially driven by labeling of our specimens or cancer cells in a two-step process. So we have our antibody of interest, either to the extracellular or intracellular targets, followed by a second step of labeling or decorating with our magnetic nanoparticles, our chlorine-linked iron oxides in particular. And it happens in a way that we try to load as many nanoparticles as we can into our antibodies before encountering steric hindrance. And this is a way we achieve kind of the high signal to noise, which is the currency of imaging and sensing technologies. Now, this happens in a very selective approach. And the selectivity occurs through the concept of bioorthogonal chemistry. So that's inherent, the definition is in the name. So we rely on reactions that occur peripheral or orthogonal to biological processes. So what we actually do is we modify our antibodies with a transcyclooctene, or TCO, and we modify our nanoparticles with the tetrazine group. So what happens, unlike, for example, our carboxyl groups were ubiquitous and there are a lot of nonspecific reactions, the inherent ring strain in the TCO drives the reaction forward and reacts with the tetrazine at room temperature, catalyst-free. So you have this kind of very selective tethering of the nanoparticles onto our antibodies. And then the device component, the hardware, comprises of a 0.5 Tesla magnet. Not trivial, again, in a 10 by 10 centimeter device compared to the 1.5 Tesla or 3 Tesla strengths of the large clinical magnets. It also includes electronics, microcoils. Earlier versions included microfluidics. We're trying to shy away from that with these current iterations. And then you see that smartphone on the top right. So the device runs, the smartphone runs the device and then essentially receives quantitative data onto the device in a very operator-independent method. So to explore kind of the clinical potential, we enrolled in a pilot study at Mass General, enrolled some patients who were referred to the interventional radiology suites with a suspicious intra-abdominal lesion. So we collected a fine needle aspirate, 1 extra pass, and then they underwent processing for both respective extracellular and intracellular markers. I must add that we weren't necessarily wedded to these markers. These are just markers that either literature made sense or we were familiar with in the lab, but certainly very versatile and we could work with your potential markers of interest. And depending on whether the intracellular or not, there was an extra step of permeabilization. And ultimately, in about 45 to 60 minute turnaround time, we were able to achieve some expression level per cell values. So there were some fundamental questions, kind of a priori. What are the expression profiles across patients, diagnostic accuracy of the marker or markers, how does micro-NMR compare to standard pathology? But really the question we were trying to address here, because this is the first time we were using human samples and we were able to do meticulous work in preclinical samples, is can we apply these technologies to human specimens and bridge the bench with the bedside? Not to bore you with the details, just gives you a sense of the spectrum of patients that we encountered. They were all essentially solid epithelial tumors with kind of various clinical histories. So not surprisingly, we found that the expression levels of the proteins are heterogeneous across the epithelial tumors in patients. Not groundbreaking discovery, but I think the achievement here was that we were able to achieve in a rather kind of point of care and fast turnaround, a very quantitative way to actually measure that heterogeneity, okay? So to the point that we could even create these kind of XYZ graphs, and in the initial 50 patient cohort, we were able to explore the range of NMR signal across these different markers, and one nor just a handful of patients drove that heterogeneity. There was no kind of rhyme or reason. Exploring a subset of these markers, we were able to identify 4 markers that gave us a diagnostic accuracy of about 96%. Interestingly, there was a specificity of 67 in a small sample, albeit, and it occurred because we only had 6 benign and 2 misdiagnoses. These essentially were from fat necrosis, so it informed us to use some inflammatory markers for future studies. And then in a 20 cohort group, prospective validation, we had 100% accuracy. But again, 60 minutes versus a kind of the 3 to 4 turnaround time for pathology. The second device is the micro-Hall sensor. And what it is we recently developed this microfluidic chip. So it's a very miniaturized microfluidic that actually quantitates in a very rapid manner individual cells in unprocessed clinical specimens. And I think that's where the key is. So what it does specifically, it measures the magnetic moments of these cells in flow. And these cells are immunolabeled with magnetic nanoparticles. We got a little more elegant this time because now we were able to achieve kind of true multiplexing because we were able to actually load them with different types of nanoparticles. So we're able to resolve these individuals' markers within the cells. The chip itself is kind of the size of a quarter and rather inexpensive to produce, so it kind of obviates the need for bulkier equipment such as optics and centrifuge. Not unlike the micro-NMR experience, there was a lot of kind of preclinical, obviously, correlation. And here with comparing flow with our micro-Hall device. So here in A, we see that in a breast cancer cell line, we're able to resolve the 3 markers comparable to the inset here, the flow. Or just looking at EpCAM, we're able across cell lines, it performed fairly similar. I think where the money is essentially at the bottom, this issue of background insensitivity, where in carefully controlled spiking experiments using human blood, we were able to, in whole blood, resolve our cells, whereas flow had encountered problems because it needed this kind of enrichment. So again, a pilot example of this technology, we looked at 20 patients, advanced stage ovarian cancer, and we drew their blood. And we compared it to the only, at least as of now, FDA-approved CTC device, CellSearch. And what we found was that there was a higher kind of dynamic range using our device compared to CellSearch, which only relies on 1 marker. And we actually used our 4 markers that was informed by the initial FNA studies. Just depending on the clinical scenarios, again, we were able to see more of a dynamic range. Again, this is a snapshot. These aren't serial testing of the same patients, so paves the way for subsequent studies and any other clinical questions you guys may have looking at serial numbers. And then finally, for those who fall into the camp that actually subscribes to the notion that exosomes are useful, then we've developed an exosome chip. It's a little controversial, but the exosomes, depending on the size criteria, anywhere from 30 to 90 nanometers, and they're shed from the cells, and some significant group believes that they're integral in kind of cell-to-cell signaling. And it posed a bit of a challenge, at least just given the small size of these exosomes, to try and develop a device. And we recently achieved that through this rather exquisite device that has a bunch of pumps and filters and channels. And we're ultimately able to resolve exosomes in the peripheral blood of patients with glioblastoma. And there was actually some clinical correlation with response based on exosome number. So the impact, so here I had mentioned that in a rather point of care, somewhat inexpensive and fast approach, we're able to resolve the expression patterns across 50 patients and multiple markers. Well, we could envision that we can do the same at kind of key nodes in someone's treatment. And in the setting of clinical studies, we could envision that we could certainly get a kind of rich repository of data from that. And in this kind of climate of serial profiling and looking at how tumors change in response to cytotoxic plus or minus targeted therapies, I think this is an important advance and a key need to collaborate with you guys. So some of the strengths: quantitative, operator independent, it's easy to operate, portable, versatile, and rapid. Thank you.